So, nobody knows anything about PoTS, which is absolutely great. So this is my approach, and as I put on the previous slide, this is what I do, and this is basically comes out of listening to a lot of PoTS patients and learning how to manage them. Obviously, lots of people will have different experiences in different environments, and it doesn't necessarily mean that either of us is right or wrong. So PoTS fits into this area of orthostatic intolerance, people who don't like standing up, or people whose systems don't like standing up. And over here, we have the faints, which is obviously a major cause of syncope, where the blood pressure control system works normally but decides to take a short holiday in certain circumstances. Then there's the more significant autonomic failures, which we'll be hearing about later, and then PoTS sits here in the middle, sort of halfway between. And it seems to be a subtle failure of the system to get blood to the right place. And it may be a number of things. It may be insufficient blood volume. It may be a failure of vasoconstriction. It may be sending blood to the wrong place at the wrong time. It may be that the heart rate response is abnormal. It may be that it's actually a mixture of all of those things. These are all physiological abnormalities that we recognize, but they're not necessarily all the same in everybody. There are definitions, and it's obviously important to remember that these are syndromes, so these are a collection of symptoms rather than specific diseases. And so I think you should view the definitions very much as a guide to the sort of patient. The heart rate increase over 30 beats per minute when standing, sustained over 10 minutes, is the definition of PoTS. And inappropriate sinus tachycardia has been defined as a persistent sinus heart rate greater than 100 beats per minute associated with distressing symptoms of palpitations. There's quite a similarity between those two things. It's very important to remember that this area is likely to all be part of this broader category of orthostatic intolerance, with PoTS patients being a part of that. But you have to remember that that heart rate increase is an arbitrary definition. They defined that on the basis of we want it to be far enough away from normal people so that we don't mix up normal people. That does not mean that there is a line at 30 beats a minute and that if your heart rate goes up by 30, you've got a condition, and if it goes up by 29, you're just barking mad. So you have to remember that there is a group of patients with some physiological abnormalities that cause them to feel unwell when they stand. So we have to think about the right sort of patient. I get a number of referrals for PoTS patients, and I get quite a number of referrals for, say, would you like to see this 69-year-old gentleman with his movement disorder, and I think he might have PoTS. Obviously, he's not going to fit into this, and it's much more likely that he's going to end up with a Parkinsonian autonomic dysfunction. So the classical PoTS patient, of which there are quite a lot, so nobody quite knows the incidence, but maybe about 1 in 500, which is the same incidence as hypertrophic cardiomyopathy, so it's not that rare. General seems to be more common in women, and it tends to be more common in younger people. So younger women are the classical patients, and they tend to present with a group of symptoms, and some of those are cardiovascular, which is why most people who end up managing PoTS patients are cardiologists, and it's all about chest pain and breathlessness and dizzy spells and palpitation. But then a proportion of them are non-cardiovascular, but perhaps autonomic, so bowel disturbance, bladder disturbance, migraines, and so forth. So we're expecting to see a younger woman with quite a lot of symptoms. And by definition, for it to be called PoTS, it needs to have been present for 6 months. So the sort of symptoms that people will describe, so the sort of things that you're going to hear in clinic will be chest pain. An awful lot of them have chest pain, but it's going to be mixtures of musculoskeletal, sharp, stabby, hurts to move, hurts to breathe in. There can be GI dysmotility. And there's also a central chest tightness that seems to run with dysfunctional breathing. So an awful lot of them also hyperventilate and feel breathless on exertion, yawning, sighing, respiration, and that can even affect them while they're lying flat. They get can get puffy ankles, but they also specifically describe acrocyanosis, this purple feet, particularly when they're standing. The palpitations relate to the persistent sinus tachycardia, but often they tend to feel their symptoms very keenly. So its ectopics are, they may be not very frequent, they may be 5 or 10 a day, but they are, oh my God, this dreadful pounding in my chest dock. Lots of dizziness, some blackouts, but not always. You don't have to black out to have PoTS, but it's a general feeling of faintness while standing up. So the full range of cardiovascular symptoms. Obviously, we want to try to get closer to the diagnosis, so using a beat-to-beat blood pressure system, as you'll find outside, can give us good ideas. So this red trace here shows how the heart rate increases on standing with the blood pressure down below. This is a patient who, to all intents and purposes, presented with PoTS-like symptoms, but didn't fulfill the heart rate criteria. However, her blood pressure became increasingly variable as she stood, associated with her symptoms, and this is, these are known as Mayer waves. This is blood pressure cycling, and may be very predictive of patients who have orthostatic intolerance. Nobody knows what tests to do to exclude other problems. This is what we do. This is very intensive, and obviously this is not necessarily something that other people would be able to reproduce in their clinics, but we tend to do an echo to exclude cardiovascular structural disorder, Holter monitoring to investigate those arrhythmias, cardiopulmonary exercise testing because so many patients describe fatigue, and respiratory function test because there's so much breathlessness. And the sort of things that we're seeing is not abnormal heart rhythm, but it's abnormal heart rate. So we tend to see this sort of pattern or this sort of pattern on the heart rate trend on the Holter. So actually that's the most interesting area for the Holter that I see. So a spiky heart rate profile, heart goes inappropriately fast. And this is one of the reasons why I'm slightly less certain that PoTS and orthostatic intolerance and inappropriate sinus tachycardia are necessarily distinct conditions. Lots of hyperventilation on the cardiopulmonary exercise test. You can do blood tests. You can do any number of blood tests that you fancy. What we tend to do is to do a basic assessment and then look at vitamin deficiencies and obviously try to replace those. It is also said that it's worthwhile doing ENA. So hopefully with all of that, we've excluded other cardiovascular problems. We've recognized the symptoms and it's in the right sort of patient. So how should we manage it? Well, you have to manage the basics. There is obviously the major focus in modern medicine about, look, I want the sexy drug, I want the sexy procedure. Can't I burn something, blow it up, or freeze it? But unfortunately, you can't yet, although when Dr. Lim arrives, no doubt he will tell us about burning things. But it's recognizing the abnormalities in physiology and saying it's not full enough, it's not tight enough, it's going too fast. So what we need to do is to try to fill up that system. So it's all about recognizing symptoms or conditions or situations where it may be aggravated, increased fluid, increased salt, cutting down on carbs, using compression clothing, building up levels of fitness, and really being very certain with the patients that this is absolutely vital. For a lot of people, just doing the simple stuff will make you feel considerably better. And then we try to make sure that they prove it. So drink lots of fluid, add lots of salt, and then do a 24-hour urine collection and prove it to me. I'm not going to spend a long time talking about PoTS and exercise, but there is more evidence that exercise improves PoTS than anything else. And that's because of this recognition that PoTS patients look rather like deconditioned patients. That is not, however, to say that deconditioning is the same as PoTS, because there's an awful lot of patients out there who are not deconditioned when you put them on a cardiopulmonary exercise test. And there's a lot of focus that PoTS is just an anxiety condition, which is not the case. And there's also been somewhat of a focus that it's actually just lazy girls and they're all just deconditioned and you need to get them to exercise. That is not the case. However, there is no doubt that PoTS patients are like deconditioned patients. And what they've found from looking at a lot of cardiopulmonary exercise testing is that there is reduced stroke volume and there's an abnormality in the way that the venous capacitance system works. But different PoTS patients have different physiological abnormalities. Some of the patients find it impossible to tighten up their blood vessels to get blood to the right area, but other people, they're already too tight and everything is underfilled. Ben Levine and colleagues in Dallas have published a number of studies looking at exercise in PoTS, and there are other studies that are going to be ongoing to prove that exercise is important. It is difficult. Not everybody completed the exercise program. If you've ever seen it online, it is very, very complicated. However, there is no doubt that of the patients who completed it, their cardiovascular autonomics appeared improved. I would take issue, however, with the fact that they said as they no longer qualified for the heart rate criteria, that meant that they were cured. That's rather larger than I think that you can claim. However, there is no doubt that the patients improved. So as Satish will be talking later on, but as he put in one of his editorials, the exercise is a treatment but not a cure. They start with recumbent exercise. They need to exercise frequently, and it may take some weeks to improve. There are a number of different drugs that you can use, and they're listed in all of the review articles. The problem is, again, that there's no particular consensus about what to use in what circumstances. I will have my own choices that I'm familiar with. You may be familiar with other things. So neurologists may be more familiar with pyridostigmine. Hypertension colleagues may be more familiar with clonidine. We do know that some drugs make things worse. This is again another of Satish's slides that I'm very grateful that he's allowed me to use. SNRI drugs make PoTS worse. They don't make everything worse, as I hope that we'll hear. So what I tend to do, and this is just me, I use midodrine first, I use ivabradine second, and then I use some other things that I'm familiar with. And then when it starts to get into complicated things, I know that they exist, and I have mates around the place who can perhaps advise some neurologists, the autonomic neurologists at Queen Square, the autonomic hypertension team at Barts, and so forth. So I think the way to think about treatment is it may be too empty, so fill it up with fluid and salt and fludrocortisone. It may be too baggy, so tighten it up with compression clothing and midodrine. It may be going too fast, so use other medications. And it may be that patients will respond to those medications according to the abnormality in their physiology. Now, I think it's also very important, and what is very clear from managing a lot of patients, is that this is not a heart rate issue. This is not just, it's going too fast, so therefore I'm going to ablate it and bung in a pacemaker, and the patient's going to be entirely cured and extremely grateful, because that just isn't the case. So it is a systemic disorder, and therefore it's important to treat it as such. So you need to find mates who will help with the dysfunctional breathing. So that's very, very common in our experience, and respiratory physio can be extremely helpful. Abdominal disturbance, so it's useful to find a helpful gastroenterologist who's going to look for the nerve abnormalities in the gut, gastroparesis, colonic dysmotility. Bladders don't empty very well. There's lots of sleep disturbance. There's an awful lot of migraines, particularly vestibular migraines, so there's a lot of vertigo as well as migraines. Many of our patients are hypermobile, whatever that might be, so there's a lot of joint disturbance. And there's an increasing interest in how a lot of our patients do seem to describe quite a lot of inappropriate allergies. So understanding that a lot of those symptoms link, and that with relatively simple treatments, that could also make a difference. So the idea is to try to say, I want to get our patients to feel 5% better from the cardiovascular side, but 5% better from their bowels, 5% better from their breathing, and so forth, and that seems to make a difference. It's important to remember that PoTS affects young people, and it has significant effects on them. So this is a study from Leslie Cavey and colleagues who run the PoTS UK charity. You can see what a significant burden of ill health this puts onto PoTS patients, and it's very important to recognise that. So, to conclude, and I probably overrun, I'll have to have a word with the chair. Recognise the patient by their symptoms more than the heart rate changes. Make sure you're not missing stuff. Make sure they do the simple stuff extremely well. Think about medications and the associated features. And unfortunately, at the moment, we don't have all the answers. So thank you very much for listening.